Hi, this is Pat McDonald, your host for Vote for Vermont, where our tagline is Listening Beyond the Soundbites. Joining me tonight is Ben Kinsley, our co-producer and co-host. Ben.
Pat.
And our guest tonight is Representative Ann Donahue, who represents Berlin and Northfield. Ann, welcome to the show.
Thank you.
You're actually a repeater. You've been on before.
That's right.
Yep. Ann served about 8 terms. 8 or 16 years, Ann. We have to chat about that.
That's a long time.
Yeah, and she's the vice president of House Committee on Healthcare.
Vice chair.
I'll
be
sorry.
president someday.
Yes, vice chair. I got it right here, and I
yet.
read it wrong. She's the vice chair of the House Committee on Healthcare. And could you just fill us in a little bit about the rest of the background, the rest of the story, as they say on TV?
Well, I was involved in youth advocacy for many, many years before I came back home to Vermont. And I've been involved in the legislature also. I'm also involved as a mental health advocate, work for Vermont Psychiatric Survivors, which is a peer organization. So I came back from dealing with a serious mental illness and got involved in mental health advocacy, and that's how I ended up in the State House.
That's great. And you're also the editor of
Counterpoint.
Which I'd like to talk to you about later. That's a great magazine. My neighbor said she saw you up, she works up on the 3rd floor, and that you're always up there delivering Counterpoint. So
That's right.
She said, I know Ann. So there you go. But when I knew Ann was coming on the show, I started thinking about all the things we could talk about, and the list was very long. But I do want to start with mental health, because that's certainly something I consider you an expert in. You have certainly been an advocate and very involved in all of the issues. So big picture, how would you categorize our mental health system these days in Vermont?
I guess there's a certain irony there, because Vermont probably has one of the better or best mental health systems in the country in many ways, and yet it is really failing, very flawed. And I guess I'd point maybe first of all to even calling it a mental health system. Why do we have a mental health system? Why don't we have a healthcare system
Well,
that
that's a parity issue.
incorporates all aspects of our healthcare, which obviously incorporates our mental wellness?
Well, talk about parity, because that's exactly what you're saying. Is the mental health, is that in healthcare now? There was a shift, right?
The legislature finally caught up with the laws it has set out for many, many years, and that is within the committee structure. Mental health moved from the Human Services Committee to being integrated in the Healthcare Committee.
Right.
So I think symbolically, certainly, and even from a policy point of view, that was a very important move that we finally caught up.
Yeah, that's right. So in your committee, you're dealing with the issues that are very important to you.
That's right.
So Ann's been on the show before, been talking about parity, that's the health system and mental health.
Right.
But she's right. It's not. It's the health system, including mental health, or it should be in the discussion of of health.
All of healthcare, and sometimes people will say mental health and physical health. I mean, what's physical health? It's all of healthcare, and our mental health is part of it, just like our bones and our heart and our skin, our brain. And I use the term holistic, meaning the whole person. Should be a holistic system of healthcare which incorporates all of those things in all aspects. It's not just about medicine, medication. It's about exercise for your heart as well as. And the same with our minds. There are a lot of alternatives that we call alternatives. It's really part of a holistic healthcare approach that says sometimes diet and exercise is what we need to be doing most, instead of saying, oh, take a pill, we can fix it all. Just help those pharmaceutical companies make their bottom line.
Exactly.
Which happens too much.
Yes, exactly.
One of the things I think that, and you kind of pointed to this a little bit, our system is so fragmented because we have designated agencies, which are basically, for our viewers' sake, are independent nonprofits that receive funding from the state in order to deliver services like mental health services and counseling and all this stuff. But it's separate. It's separate from our healthcare delivery system because it's state funded, and they're accountable to the state, and their clientele or their patients are specific to meeting the requirements of the state. But yet they're competing for the same jobs that hospitals are competing for. The same folks that work at a designated agency in mental health are also working at hospitals. Hospitals can pay them more, so that designated agencies have a hard time recruiting.
That's well explained. It's the mental health workers often are second-class citizens, just as their clients are, which impacts the ability to get care, to access care if the providers aren't there. So it's important to remember that that is a part of our history of discrimination. The reason that community mental health centers came into being in the 70s was because we were not providing mental health care as part of our healthcare system.
Right.
Even if you had insurance, your insurance didn't cover it. So the federal government actually was the one that first started funding and creating a system to fill that gap. So if we were to remake it and say we recognize now that it should have been a part of our healthcare system from the beginning, it would be a very different system.
Right.
That wouldn't exist now. We can't turn around and say, okay, let's eliminate all those agencies and make it part of our healthcare centers. We have to see how we blend them and how we make it be integrated now that we have the structures we have.
Well, and we see some of these growing pains as people, Americans have gotten much more open about mental health issues and seeking help for mental health issues. And oftentimes their first point of contact when when someone's having a mental health crisis, they show up in an emergency room.
That's right.
And you can tell that, when originally they were conceiving of a healthcare delivery system, they really weren't thinking about mental health, right? And that's apparent in the way that emergency rooms and walk-in clinics are structured. They're not structured with staffing that can respond to those types of needs.
That's right, and it's
nimbly.
because of some of the staffing shortages in the agencies, they can't provide the salaries to retain staff, that people reach more of a crisis point and end up in an emergency room.
Right, yeah.
Didn't necessarily need to be there if they had been able to access somebody, but they're on a waiting list to get help. They end up in an emergency room, which is the last possible place that would be useful or helpful to somebody in a crisis. I've been there in that situation.
It probably makes people more stressed.
Absolutely.
And it's not a good environment for the patient, and it's not a good environment for the healthcare professionals that are there. They're not set up to deal with.
And we've seen a significant increase in the number of people seeking out emergency room help, which has contributed to backlogs where people are waiting for days and days and days, which obviously is huge impact on the helping professionals who want to be able to help. But an emergency room is not a place where you get care. We wouldn't leave somebody who needs to be in the cardiac intensive care unit in an emergency room for days. We would know we couldn't deliver care there.
And the cardiac patient can't wait a couple of days, right? So
that's right.
These people in crisis need the help.
People need to be getting to the care that they need right away.
Right.
But the disparity in our system right now is it's people in a mental health crisis who are left waiting, who end up in crisis because we don't have the supports available, and then who are stuck there. And that number continues to increase. It's staggering to me.
It's an issue that's getting worse, and we don't have beds in actual mental health facilities that are set up for that. We don't have enough of them, and so people are getting stuck in emergency rooms because that's where they're going. And
they're not separate facilities. They are our hospitals, our psychiatric units. We might not need as many beds if we were keeping people from getting into crisis.
Right.
But clearly, right now in the moment, we don't have the beds we need, which is why the legislature started acting to try to fill that gap. But if we don't also fill the community gap, we could just keep building more beds forever. If we don't fill the need for other peer support folks, of the kind of housing supports, all that sort of thing that keeps people out of crisis. And we took some positive steps this year. It was good to see. There's a long way to go.
Could you talk about that, the legislature, and then we can get back. I was going to ask about the governor's mental health facility, but what happened in the legislature this year? Was there a positive steps taken?
There were several. One was another real boost for the salary structure for community mental health centers, so-called designated agencies.
Because Mary Moulton's been on this show, I don't know how many times, and they're desperate.
Yeah.
People just,
at least twice.
Yeah, they leave.
They can't, right, people leave, there's the cost of recruitment and training, and they have so many vacancies. They can't, and it's a drop in the bucket, really, in terms of parity for staff as far as what they could get in a hospital or working for the state in other positions or schools. But it is a start. It's the second year in a row that we've put significant money to boosting that. And we also put aside a piece of the sort of one-time money from a lawsuit settlement, put aside a piece of money for training, recruitment, and professional staff retention for mental health and substance use disorder specialists. So for bringing on board more folks, which is absolutely critical. And then the last piece was putting a plan in motion to develop more inpatient beds. The missing piece is still some of the front-end programs.
Well, that's the wellness
couldn't do
approach.
everything.
Stop it before it happens. In this case, stop it before it excels.
And we totally have recognized that and have realized that when it comes to other health care, because our focus on prevention, on primary care, we need to intervene then before things get worse. We've got to put that same focus on mental wellness.
So talk to us about the governor's plan for his new hospital. I think you were a no on that vote, were you not? Because you were more focused on, well, you explain it instead of me.
Right. The governor's plan came in, the secretary of the Agency of Human Services came in with a plan saying we desperately, clearly need more inpatient beds. And I think their mind frame was what's the fastest place we could, put a plug in the bleeding artery. And they thought the fastest way was to do them within our correctional settings for the subgroup of folks who come in to needing psychiatric care, who come in through the correctional, through the through the court system. So that was the proposal they presented, and our healthcare committee said that's not appropriate healthcare. It doesn't matter if somebody is having a heart attack and they are in law enforcement custody. We don't say, let's create a cardiac unit in corrections. We get them to the hospital and we stabilize them, and then they may need to end up in corrections. But they go to a hospital. And so we said, no, forget it. We did agree that there was a need right now, and maybe that we can ease other things and back off, but for now we clearly need more inpatient beds. And so we did support the concept. But we redirected and said, it has to be integrated in our healthcare system.
The one thing I think in that plan was that there was more of a holistic, that there were a lot of wraparound services supposedly in that hospital setting, where maybe more counseling and that sort of stuff would be in that facility. Am I misunderstanding?
Well, it's more of it's a new prison that they would be building up in St. Albans. But it would include, as a component of it, both an on-site clinic, a health clinic, and a mental health clinic. So, and then whether or not those two would be the same thing would be a little different.
I don't
but
know.
that's sort of dropped off the radar. Other than, there is one piece that was important, and that was for folks who are in the correctional system who need enhanced mental health care, but not hospital care. Like somebody in the community who might be in a supported living situation because of mental health. They did expand and enhance some capacity for that need appropriately in corrections. But hospital care belongs in a hospital. And so it sort of meshed with work that the University of Vermont Medical Center was already doing to try to enhance the approach to the need for inpatient mental health care. They have been behind that effort for a long time. And they ended up having this, Green Mountain Care Board thing with some unanticipated revenues that were not permitted under the regulatory scheme. And so the consensus was, on their part, let's put that money into kickstarting this new inpatient unit, which would be located centrally, meaning their Central Vermont campus. and as part of the expansion and rehab of that campus to centralize some significant inpatient.
How is the state hospital doing here in Berlin? Is that still facing troubles, or things have calmed down a little bit?
Well, it's still facing, a major financial hurdle pretty soon.
Really?
The federal government has, we have a waiver. We're under a waiver.
Right.
The law for a long, long time has been, because the federal government has been focused on integration.
Right.
If you're not integrated with a medical center, you can only have 16 beds.
And we have more.
And we have 25,
right.
And it's not integrated with a medical center. And so within a 5-year time frame, the federal government is going to begin cutting off funding for that facility.
Excellent.
So that's why part of the plan is to potentially relocate those intensive inpatient beds within this new integrated medical center with a psychiatric connected unit. And then that new hospital could become our secure residential facility.
Oh, I see.
So there's a lot of moving parts,
I
because
can see that.
there's another piece that says, and that's going to take 3 or 4 years to build that. What are we doing in the meantime? We've got a lot of people waiting.
Because there's a lot of planning that went into that hospital. You got to think about the window, just think about people leaving the facility and how you can prevent that, and the services that they need if they're in crisis.
So the other piece of the plan is an interim unit, 12-bed unit, that's going to be added down at the retreat that the state is funding in order just to,
Great.
stopgap, temporary piece. Because that's, of course, that model is not a modern model of care anymore. It's not integrated with a medical center.
I'm sorry, I don't mean to, because we're not
Yeah,
ask
we're
this
at it.
question, but they put when they put the facility on the property of the Center for My Medical Zone.
Yes.
Silly me, I thought they were going to be working, but they didn't want the medical center to weigh in with the treatment, and I think the president said if we're not able to weigh in.
It's a little sticky.
Yeah.
There's liability issues.
Right.
If you don't control the staff, how can it be part of your hospital if they don't work for you?
Exactly.
And so
I don't blame her, actually.
I
After
don't
heard that,
either.
I said she made the right decision.
Yeah,
But
yeah.
anyway, sorry, Ben, I'm just blabbing
No,
away.
that's okay. That's all right. So we've been doing a series of shows working with Jolinda Leclerc, who's the opioid coordination
Director
council.
of Drug Prevention something.
Exactly. And so we've done a number of those shows, and one of the shows was on the co-occurrence of mental health and addiction. I don't know if that's something that your committee had looked at or not, but it's a really interesting, if there was a Venn diagram for this, it would be really interesting. But is that something that your committee has looked at all?
We have looked at it some, not in depth, and this really sort of goes back to your earlier question about parity and our recognition, moving mental health into the healthcare committee. Nobody can do everything all at once, but what we left behind was substance use is still in human services, even though it's really integrated with mental health.
Of course it is.
So we got to get there. We got to get there, but it doesn't mean that our two committees didn't work together in looking at it. And one example is the professional development funding that I mentioned before, which is for both substance use and mental health. And we're very cognizant of it, and it really goes a lot to what I know you have as a question in a few minutes. But when we start talking about trauma, and it's not just childhood trauma, but a lot of it begins with childhood trauma. And we know more and more through science what we knew intuitively for a long, long time. A lot of what we call mental illness, or ends up being diagnosed as a mental illness, is a rational human response and protection to extreme trauma. And so is substance use disorder. Right. Whether you call it self-medicating, the roots are trauma. And that's why it's so scary to see what's happening now, because of course it becomes a cycle, because when parents are dealing with opiate addiction, or their mental well-being is not stable, that's going to impact their children, who are then going to often become the victims of really toxic trauma. And that cycle is going to continue. We are just beginning in our schools now to see the children are getting to be school age who have been devastated by the opiate crisis, and who are really, really having a lot of needs.
Well, I've said this on some other shows. I'm on the Prevent Child Abuse Vermont board, and we had the numbers of child abuse going down.
Yeah.
And then with the opiate crisis, the numbers have shot up, but it's not abuse, it's neglect.
That's right.
Because people are zoned out and not taking care of the kids, throwing them in the back of the seat and puffing away, and a lot of damage is happening to the kids.
That's right.
It's not physical abuse.
Well, we heard a story actually from the Chief Justice of the Vermont Supreme Court, who was testifying to our committee work group on childhood trauma, about a child who showed up for preschool on the bus, got off the bus in a diaper with a lunchbox, and the lunchbox was empty.
Oh my God.
And that's how this child arrived at preschool. So that's the depth, that's exactly what you're saying.
Right.
Wasn't being beat up.
Yeah, no.
But
neglected.
But that kind of loss of a parent figure who's stable in their life is what's absolutely
and for the child,
toxic.
The self-esteem, somebody loves me, it's gone.
That's right.
Yeah. Well, and I think it's in some ways it's cause and effect, right?
That's right.
There's almost always a cause. Well, there's always a cause. It depends on the situation, what the cause is. But something in the case of substance abuse, at some point you had to have the circumstances that led you to make a decision that eventually got you in trouble. Right? Got you into a place that you can't come back from. And the circumstances to making that decision, that's not a personality thing necessarily. I mean, you can be more prone to addiction because of your personality if you have an addictive personality, but at some point there was a trigger.
And we've seen even that sometimes, or in some cases, it's simply having started on an opioid for pain management.
Right. Well, that's what the doctors we had on one of our panels, they insisted that's where most of it started from.
I don't know if it's most, but it's certainly a significant piece.
I would say even though, and that's where a lot of it starts. I mean, drinking addictions can start that way. You have one, but at some point, I think you hit a point where you pick up a pill or you pick up a drink, and you say, why am I taking this one? Like, what is it because I have pain?
Right.
Or is it for a different reason? And at some point, I think everyone probably has that moment.
But at that point, it may be too late to figure out which decision you're making.
Exactly.
Yeah, because I don't think people would logically make that choice if they were clearly thinking.
And I know people that have gotten to that point with alcohol where they got to a point where they're like, I could see myself not stopping, and they
well, good for them.
And they won't touch it again.
That's good.
Because they got to that point and saw the.
Well, we had a big discussion there were 3 women who, 2 of them were of dual license, both in addiction and in mental health, which is very rare. I mean, it's a good thing to have. One was in the Department of Health, and the other was at the facility in Burlington.
Howard Center?
Howard Center, thank you. Anyway, we were talking about how difficult it is when you've got addiction and mental health and you're supposed to take care of it all. I mean, what goes on in somebody's mind must be just incredible, and body with the addiction. I mean, how you make changes. It's got to be just gradual for the rest of their life, right?
That's right.
And they have to be committed to that. Oy. Anyway.
So we've talked about one of the biggest challenges with the mental health system in Vermont is the staffing piece of it. What are the other big challenges that our viewers should be aware of in terms of, increasing access to mental health facilities and mental health care?
We don't have enough folks to begin with, so recruitment and retention is critical. But we also don't have enough of some of the alternatives to what you think of as the typical model. Somebody going to a professional or going to a doctor and getting medication. One of the examples, peer support, which we see so much of in healthcare as a whole, recognizing that support groups in, cancer support groups, so forth, means so much to be connected with people who've gone through the same thing.
Right.
So things like peer respite for people in crisis that are run by peers. peer centers. We have little bits of that in Vermont. We could do so much more. It goes back to that issue of prevention and early intervention.
Right.
When somebody realizes they're in trouble, if somebody's got the hand there ready to help them, it can.
Is the hub and spoke system set up to help mental health?
The hub and spoke is substance use
okay, strictly addiction.
And a lot of it is very focused on the medical components.
Okay.
The medication assisted treatment.
Right.
Because we did a show on alternatives to medication.
Yeah.
You know, the therapy and all this stuff, and but there really isn't that much for mental health, is there?
There is in terms of therapy,
relaxation and
right. That's exercise,
right.
all of those different
massages.
pieces. Yes, yes.
Sign me up.
Would the hub and spoke model, do you think would work for mental health? Or is that a viable option? Because
it's a very different structure. No,
yeah.
I don't think it would really.
I would almost think
parallel.
like a hub and spoke in reverse, where like your intervention are your spokes, and then the hub would be like a crisis. So it's kind of the opposite of what the.
Yeah, that might be.
It would be interesting to see, but
right.
but I think even talking with Washington County Mental Health, they have, I think. Only 60% of all positions they have available are
right.
filled.
Yep.
Yeah.
So they have a 40% vacancy rate basically
right.
for their staffing, which is
right.
incredible. I don't know how you function, any organization functions like that.
Right. Means that you don't have, when it comes to the crisis services, you don't have the people there able to respond. That's part of, if people are waiting in an emergency room and there isn't a crisis worker to what's called screen them, to determine their needs and try to help out in that.
Right.
They're not available for that. When it comes, can you imagine building a therapeutic bond with somebody in therapy, trying to work with somebody, you gain their trust, you do all those things, and then that person leaves. Right. And you've got to start over again.
Yeah.
It's not like continuing to see your same primary care doctor for your medication of your high blood pressure, where yeah, it's tough if your doctor changes. You had somebody with a rapport. It's not the same as somebody you've shared your, your
right.
deepest feelings and.
Yeah.
Sorry. I have a friend of mine who has a child but was over 18. In the system, 18 can do what he or she wants.
Sure.
And I read an article about this woman who's trying to sort of fight that if it's very clear that this person, the child, has been under state care for 18 years, but when they get to be 18, they can make their own choices, and sometimes it's not the right choice for them, and they put themselves in danger. Is that something that, I know that's a surprise question, I just thought of it, but my friend really struggled. She loved her son very much, but he was making wrong choices.
So if a person is 18, and their mental state is such that they are not competent to make their decisions.
That's huge.
That's huge, right. That's something very different. If they're making bad choices, you know what? A lot of 18-year-olds make a lot of bad choices. And in this case that you're talking about, it may have had to do with his mental wellness. Other kids are doing other things.
Right.
If we decide somebody's an adult, it includes, if you will, the right to make bad choices. And
right.
It's terrible for parents for any kind of bad choices their young adults are making. But that doesn't mean we have a right to intervene
because
and
once
take
you start
it
there,
away.
Once you start there.
That's right.
Well, unless we want to have the answer.
Unless we want to change and say it should be 21, that
right.
that you're not an adult. And then let's not draft them and send them to
right,
war.
exactly.
Let's not have the death penalty for criminal actions. I could get very passionate about this because I am,
I just read the article, and knowing somebody who was in that situation, I was leaning towards, because, you don't want to see your children, and they're still kids. I don't care if they're over 18. They're still your kids.
It's agonizing to see your kids make bad choices, but
and
that's
there's varying levels of maturity at 18 also. You can have a very mature 18-year-old, or you can have a very immature 18-year-old.
Okay, I changed my mind.
But the other thing that's important too is that the state can step in and take away certain certain decision-making
Right.
authority,
Well, that's
even
when
as
it's
an
really
adult.
bad.
If a
Right.
person is not
When the courts
legally
intervene
competent.
and say, your mother's in charge, you can't make decisions. But
Right.
that's pretty serious.
And that does happen with mental health
Yeah.
care.
It does.
A state can step in and say they can say you need to medicate or you need to take
Right.
these services or whatever.
Or you're in the hospital against your will.
Right.
Right.
Yeah, and it happens, and
Right.
it's unfortunate when it happens, but
It is.
Yeah. No, you're right. You have to draw the line somewhere and take the consequences, good or bad.
Right.
Okay, fine.
well, that's one of the consequences. Is,
Exactly.
is if it gets to that point, the state can step in and say,
Yeah,
you don't have a choice.
you don't want the child to get to that point because that's pretty
Right.
serious.
That's right.
So, anyway, so you were talking a little bit about childhood experiences. You're on this group of childhood experience group. What is that group about?
We were what sometimes called a summer study committee.
Yeah,
A group of six legislators,
Yeah.
3 senators, 3 representatives. We had hearings around the state to really try to learn and get a picture of what is this. What do we mean when we talk about childhood trauma? It's not about skinning your knee falling off a bicycle.
Right.
It's about what we call toxic stress, where your normal stress hormones are designed, to run away from the tiger in the
Right.
jungle, as and that's our normal reaction. And then they settle back down. You come back to a safe place. If you are in constant fear, you constantly don't have a stable point in your life. That's when those hormones can really affect the brain permanently. And that's what we call toxic stress. It's toxic stress that just stays in a steady state. And it's that kind of stress and trauma that can lead to lifelong problems.
So what were the conclusions? Did they come out with a report or?
We did.
I'd like to read that.
Yes, we did pass a bill as a result that really focused a lot on education, greater awareness, but also to try to track what are we doing as a state and what are the models that are working and what
Good
are the
for
models
you.
that are duplicating
A
each other.
study committee that actually had a bill passed? Good for you, Ann.
That doesn't happen.
They don't
very
do that
often.
very often.
We hope it really produces
Excellent. I have to go read that.
So just maybe top 3 takeaways for people who are dealing with stress? What are good ways to handling that, or what are some of the thoughts that the committee is moving towards?
For children who are
children,
in that
yeah.
situation?
I have children or adults.
Well, for a child, the most critical thing, we've known this for a long time, but the science is bearing out, is an adult in their life that they can rely on, that they know they can rely on.
They can go to and
Yeah.
One of the most moving things I heard as a member of that committee is when we had one of our state representatives come and testify about his childhood and the extreme, the toxic stress, the toxic childhood trauma that he went through, and what it was that helped him make it out and be obviously a successful adult. He's a very articulate representative. He's well respected in the legislature. He was choking up as he testified to us.
And it could be a teacher, could be a neighbor, anybody that you can go to and rely on.
That's right.
And what kind of things show up down the road for kids that grow up in a toxically stressful environment?
Cancer, heart disease, labels, diagnoses of mental illness, substance use, all across the board. It's all kinds of health complications that show up as a result.
So it's interesting, out of the things you just named, most of those, almost all of them, are physical things that show up because of an unaddressed mental issue.
That's
Quote,
right.
Unquote,
That's right, which
mental.
really goes to show how integrated our mind and body are. There's just so many studies. Patients who have heart disease, you can identify a significant piece of their prognosis if they also have depression. Their cardiac condition is going to, these things are, you can't segment us out. One of the things you're mentioning, if you want me to get really worked up, you could throw out the term behavioral health, which people have used as a label for mental health and substance use issues. And I would suggest to you that behavioral health is, Are you exercising to help control your diabetes? Are you watching your diet as related to your cardiac? That's behavioral health. And it may apply to your mental health as well. You know, are you doing meditation? Are you taking that walk to get your stress down? But behavioral health implies kind of this fault thing. It's your bad behaviors, you know, that make you have a mental illness. And so it's a very negative connotation when it's used to mean mental health and substance use disorders.
Well, and I think it's interesting because there are a lot of parallels. And so my wife studies neuroscience, and so she's getting an undergraduate in neuroscience. And one of the things that, and she'll show me MRI scans of like, here's what someone with a substance abuse disorder, their brain physically changes. Here is a before scan and an after scan, or someone with Alzheimer's. You can see. And
you would see that with toxic childhood stress.
Yeah. Yeah, and people with sleeping disorders physically changes their brain.
Right.
You know, they were talking about that on the car coming over with these incredible children who have been stuck in the cave for 2-3 weeks in the dark, and then it takes them 6 hours to get into the kids, and it takes 6 hours to get back out in these crevices, and I mean, and they brought them right to the hospital, but they were talking about the long-term potential effects. They're keeping them.
But they had one another. They were. I mean, I'm not saying that it wasn't devastating and traumatic, but there's also a word called resilience. This is not a terminal condition where there's no hope. Children can learn and develop resilience. And in the same way, we have only learned in the last 10, 15 years about what your wife would know, neuroplasticity, that brain damage, brain effects like that are not irreversible. Our brains can compensate. And so, yes, an MRI may see it change, but unless it's a degenerative illness like Alzheimer's or something like that, that can change. It can change again.
Another part can get stronger and compensate.
That's right.
There's hope.
It really is amazing, actually, how much neuroplasticity our brains have in terms of, you know, they've done this with like gunshot victims, right? Who could take or head trauma, something where the brain is physically injured, and is able to shift that function in the part of the brain that was damaged to a different part of the brain.
Right.
And to be able to regain that functionality. You may not regain all the functionality, and other things may be impacted, but to be able to do that is pretty incredible.
It's like it used to be thought, you know, going back to that, do you pop a pill to deal with whatever kind of disorder it is? Or can you make the same changes to your brain and body through exercise,
something else,
through meditation, through, you know, and we've learned yes, because we are whole beings.
Right. Well, and it goes back to, you know, an addiction is difficult to overcome. It's a difficult thing to overcome. It's not easy.
Right.
But going back to some of those changes that you saw and that you can see in MRI scans, those changes can revert.
That's right.
If you can get past the addiction, and the same thing is true of most mental health diseases. You know, you can get past it and, you know, heal.
Okay. We have to move on there. We have a bunch of stuff to talk about.
All right.
I don't
know if I want to ask you this, but because it has nothing to do with anything we've been talking about. But I was just curious about the saliva test. We've had these issues about opioid, and the issue is, how do you prove whether somebody is, that you can prove that they're on drugs, but are they impaired?
Right.
And the saliva test was something that they could do roadside, and the legislature, I think it passed
the House. It did pass the House.
But the Senate rejected it. But you voted no.
I voted against it in the House. So you said the saliva test can show if you're impaired. Well, it can't.
Oh, it just shows if you're on drugs?
It shows if you're on a whole bunch of different substances, some of which are legal and some aren't. It shows a whole bunch of different things. And it doesn't tell us anything about levels that would make you impaired. So they're supposed to, well, you know, we know impairment because that's why maybe you got pulled over because you're weaving and you can't walk a straight line. And if you're impaired, you know, you can then be taken for a blood test, which would give you something
Specifics,
accurate.
right.
The saliva test only, so the saliva test, for instance, could say, aha, okay, you have been smoking pot sometime in the last several days.
Right.
We don't know if that's connected to your impairment or not, but it might be. So people say, well, that's helpful. That would be helpful because maybe you would be allowed to leave, but this will help narrow the scope and say, no, we need to take you the next step. And my reaction was, wait a minute, we're saying that this test doesn't tell us anything for sure. And it might make the police officer who would have brought you in based on your behaviors
right.
to say, oh, you can go because you turned up negative on this. That's as scary as the thought that it would make him keep you when maybe you should be
released. But it would also show if I have a prescription drug in me, it would show that it's a narcotic or something.
There's a list of drugs, and I can't recall or tell you off the top of my head what they are. But it is more than just a few, and it doesn't tell you an impairment level at all. We don't know what level.
They don't know that
impairs
yet. I
you.
said
This is something like it's a swab, and you put it into like a thing.
But people worried
dip
about
it
it being
changes
used
the
for
color.
DNA too, right? They were worried about what other uses you could for the swab.
Let's come back to DNA when you get to that question about is there anything, what was your question about, anything you're particularly pleased with as an accomplishment this session?
Oh, yes,
get back to
hurry
DNA.
up, we only have 16 minutes.
Okay.
So zip through that counterpoint question.
Yeah, so we touched on this earlier, but you're a publisher and author, I think, of Counterpoint, which is a part of the Vermont Psychiatric Survivors. Can you talk a little bit about what this newspaper is and what it does for folks?
Vermont Psychiatric Survivors is a peer-run nonprofit with a core mission of advocacy and empowerment for people with labels of mental illness. And so Counterpoint, as its newspaper, is really about helping to empower our peers, educate and advocate, and educate the broader state as well. But it's really focused at people with mental health labels, helping them to know what's happening, what they may want to get involved with, what sort of issues are confronting us. So there's a lot of commentary. People write, people share their artistic expressions, and also news coverage of what's happening, whether it's in the State House or statewide issues or even some national issues.
Good for you.
And this is for the families too. It's not just for
I'm sure it's
the
helpful
families
for the
are all in
doctors.
on
That's
this
right.
too.
It's for everyone. I've heard from a lot of people who pick it up somewhere and learn a lot from it. Our number one constituency, if you will, are our peers, our own peers.
But I would
we're
think
all
that
people with a label of mental illness who have experienced discrimination and who are trying to help fight
But how
it.
helpful for the doctors and the nurses
That's
too
right.
to say, hey, maybe there's a little truth to this article here.
Well, and some of the headlines include, like new psych hospital proposed, survivor exposes police violence, new inpatient wing proposed in Central Vermont campus. So a lot of different
All
things.
new stuff.
Yep, that's right.
Good for you.
It's
So
very
let's switch to the session.
Yeah.
Because I know you wrote a couple of articles. One was a sad and shocking chain of events in the State House, and then the other one was a night of rancor in the State House. And I heard from a couple of people that they've never seen it this bad ever.
The Friday day and night in the State House when we were trying to grapple with resolving the budget crisis. No, I have never seen it like that. I have never seen people going back on their word. I have never seen such turnabout in terms of we're going to do this. No, ditch that. I'm a committee chair. I just presented this to you and had you all voted to support this, and now I'm getting up on the House floor and say, oh, forget that. I've got a different proposal. And, oh, you're questioning me about the first proposal? No, I think that was really a bad idea.
Whoa,
Yeah, it was pretty startling.
Bad.
It's interesting too. I think you can kind of see when you you know, when you start squeezing, you know, a legislative body like this, you know, you're trying to fit an elephant through the head of a needle. It's like, you know, the eye of a needle. It's really, you're going to see things, people do things in that type of situation that they normally wouldn't do. And I think
did they realize afterwards that they sort of messed up, or they didn't care because they got it done?
I don't know. I think people at that point really just wanted to bring it to an end, and there were people who were defending it, saying, well, you know, if the Speaker of the House has an agreement with the governor, of course it doesn't carry any weight if the other you know, the other body.
Right.
Well, you know, if the agreement had been, if my colleague in the Senate agrees, then this is what I'll support.
Right.
But when you make an agreement, you know.
Yeah, we ran an event where the governor was explaining all that had happened. He was actually at an event that Friday night. He came and spoke and ran back to the State House. And he said that he and Mitzi had made an agreement, and then Tim Ash didn't like it, and so she said, nope, it's off the table, and everybody was standing there with their mouths open. So
it's like, where do we do now? I mean, I don't think I've ever seen a budget come within 5 days of missing.
Exactly,
missing the fiscal year.
Yeah.
Now but we lost 2 whole weeks because of spinning wheels on this alleged compromise that would solve part of the problem, but not get to the roots of it. And people were saying, well, wait a minute, this doesn't solve it. Why should we support this?
Right.
Oh, we're gonna push it through because it's a compromise. Well, no, the governor is going to veto it. Well, we don't care. Well, then what are we doing?
Well, there were 3 budgets. You talked to me about, I think, number 2 budget, and I think you voted yes for that because you thought and there was some.
No, the first budget I supported. The budget, it was the tax bill that had the issues. The second one, where a lot of people said, hey, you voted for the budget. Why did you people turn yourself around just to support the governor? It's like, wait, that wasn't a budget bill. That was a budget and tax bill.
Right.
It combined them. It was not the same bill. And everybody said, oh, it was the same bill you voted on before.
Yeah, but just added on all these taxes.
Just added on the taxes, yeah.
Right. I compliment you for getting through that, because I've heard from several other members that it was pretty disturbing.
It was messy.
It was messy.
That's good.
So you are running for re-election for your 9th term. Congratulations on sticking it out that long.
We're glad you're doing this.
What are your goals for the next legislative biennium, and what do you want to see accomplished? Clearly, if you're running again, you have things that you want to see movement on, and so what are kind of those things for you that you want to see?
Yeah, you know, I started out in the legislature, and to this day, I feel that I don't ever think beyond one term. I don't think of myself. I'm stunned that I've been here this long, but I feel as long as I look back at the end of 2 years and feel, did I help the state? Did I achieve things? Do I feel it's still, then I'm willing to ask people, do you want me to go back? There's always unfinished business. And now that I've become so deeply involved in healthcare reform, that to me is, what do I want to go back and see more work on? We just have huge work on making healthcare more affordable and accessible. But there's a lot more than that in terms of the role that you play. And I think it's really important that, I'll tell you, if our House of Representatives, if 90% of the members had been there 10 years or more, I'd be saying, we need term limits. And we don't need these people who've been there 8 terms like me. What's really important is a balance, because we don't have that many people. There's real importance to having institutional memory.
Yes, yeah,
you come back, and a lot of people are new every year. We get a committee put together, and we've got half the committee who are brand new, who have the whole healthcare system to learn.
And this session, you had the new speaker and the new Senate pro tem and a new governor.
And our committee of 11, only 5 had been on the committee the prior term. So there really needs to be that balance, and I think that is something important that I bring, is the institutional
you need
history.
Both. You need the institutional knowledge.
You need the new ideas, the freshmen, absolutely. And I think we have a good blend of, you know, short, middle, longer.
There's going to be a lot of turnover this year. There's going to be a lot of new faces in January.
And a lot of leadership new faces, a lot of committee chairs after many years who are leaving. So,
well, if there's anyone who reads every bill, who communicates with her constituents, you do a great job, Ann.
It's a really sad thing
and
to
you can
say
that coming from the mouth of a constituent.
Well, but seriously, she's always writing in Front Porch Forum. There's always, and she's very accessible. She's at a lot of meetings, and reads every bill.
And I read
every bill.
Everything that comes to the floor.
She reads.
And I do have a reputation for that, and sometimes people get a little frustrated because a lot of times that generates an amendment saying, you know what? We rely on the committee system, but even if you're in a committee that works really hard, you can miss something. You're too close to it. You step back and say, whoa, what about this? So I think the body as a whole has an important obligation in terms of scrutinizing bills that come to the floor and not just saying, oh, they worked it through. I don't know that area that well because I've focused in my committee, so we're just going to support what the committee did. And that's a little risky.
And I know that you do have a reputation for that. I've even heard a couple of members say that they rely on you to read the bill to tell them what they should be concerned about.
When Ann stands up, you could drop a pin in that place.
Yeah,
everybody's listening.
Everyone's listening.
You're following in the Representative Koch's footsteps there, because he did that too.
Yeah.
So our final question really are kind of the flip side of that question I just asked, which is what things have you accomplished that you are most proud of or that you feel like you've made the most progress on?
It really runs a range from small and specific to larger. In terms of healthcare, I think I'm really proud of the work that I did on creating our system of oversight for accountable care organizations. Whole new way of delivering health care in the state, really created an animal of the federal government. We wanted to see it involved in not just Medicare, which it was doing for the federal government, but but also Medicaid and private insurance. So creating this kind of mega, and you can't allow a monster to grow if you're not watching what it's doing. And we created a statutory framework for real strong oversight and accountability, and I played a very key role in developing that legislation. I'm very proud of that.
Good for you.
But on a narrower level, and therefore maybe a little bit more passionate, an example of one of those bills that came to the floor from the Judiciary Committee, very long, complex family law bill, reworking everything about how we deal with child custody decisions. It really needed to be updated. Our family structures have changed. It was an excellent bill. It was very detailed, very complex, but really well thought out. Doesn't mean it was perfect. So there was one piece of it that said that a DNA sample could be taken from somebody who was not a party to the case, but who was necessary to help establish paternity. So let's use an example. Pat?
Pick on me, and go ahead.
Your nephew has been kind of a man about town.
Right,
And then he skips town. And there's a little baby. And the mom of the baby says, that was your nephew who's the father. And I want to establish paternity because guess what? He may never come back, but he may inherit money, he may end up having a salary. I need support for this child. And the judge says, well, gee, how are we going to establish paternity? He's not here. Oh, well, we know a lot more with DNA now. We can get a familial paternity. We can make Pat turn over a DNA sample.
Ooh.
Even though she's not a party to the case at all. We can mandate that she turn over a DNA sample because it's necessary for determining custody of the child. And I said, well, okay, I get the importance, but doesn't this person have a right to be heard? Have a hearing? Don't they? What happens to the DNA?
Right.
Do you promise it'll be destroyed? So I presented an amendment requiring a hearing, notice, an opportunity to argue as to why it was not overcoming your rights. Right, and that it be destroyed.
Right.
So the parts about a hearing and notice got incorporated.
Good.
That was terrific. the part about destroying the DNA, the committee opposed because they said, it's last minute, unforeseen consequences, we don't have time to think it through. And so I asked for a roll call vote and lost by one vote on the House floor. You know how rare that is, because that meant I had a lot of Democrats who joined on my side, who switched sides. So it lost, and so one of the examples of where some longevity in the blend helps, because you have relationships. I was able to talk to a few senators who said, wow, that's really important. And they put it in the bill on their side, and it is now part of the new law.
Because I might agree, but I sure wouldn't want my DNA out there
in the files somewhere.
To be in one of those CSI shows.
There you go. There
pop up, it's Pat McDonald.
So we can still demand it of you, but you have a chance to argue against it, and once the court case is finished, it gets destroyed.
Thank you, Ann. Thank you.
You're welcome.
She's really amazing. When I was the whip, and I'd call her at night, and whatever I'd email her, she'd be on the phone late into the night. I just read that bill, blah, blah, blah. So very good. Excellent. We have 2 minutes. And, we have to ask about the key areas. Got to ask.
The key area.
What she's running on.
Well, yeah. So this is kind of the same question I asked, but what key areas are you focusing on, going forward?
Well, I think they're the big topics that people think you can influence that you really can't, except that you keep being a voice. We keep punting again and again and again. It's why we had the budget crisis. We keep punting on the fundamental education funding system and reforming it.
Yeah.
You
sponsored a lot of bills about education this year. I looked that up.
But the bottom line is, the committees that work on that are the ones who have to pick up the ball. The speaker has to insist that there be serious action. Right. I can be a voice, and that's a key issue, but it's not something I can go in and actually be the one to make it happen. Continuing the work on healthcare reform and affordability and access is, on a personal level, my highest priority going back. But education financing reform and affordability for people in Vermont are, the overarching big issues. Healthcare is a huge piece of that. If healthcare isn't affordable, you can't say that living in Vermont is affordable. Education funding, a big piece of it is the cost of healthcare.
You did some work on ethics too, didn't you? Run a bill or two about ethics, because that's a big issue. When Ben was with Campaign for Vermont, that was their ethics, right? And we finally got it passed, but
not perfect.
Still not perfect, not enough teeth, but it's
there. But a first step.
Yeah, that's
good. First step. And they're going to have to come back next year to deal with it again. We built that into the bill so that they'd have to come back.
That's good. That's always good.
Yeah.
Having those, having those mechanisms are important.
So you out knocking on doors and doing all those things?
I am fortunate enough to not have a primary.
Get out. Oh, I didn't know that.
So I don't need to be doing that.
Good for you.
The Democrats in the district have a primary, 4 people running for 2 seats. I have a running mate, Ken Goslin, who's select board chair in Northfield. Terrific guy. So we will have a race in the fall with whoever survives the Democratic primary.
Good for you. Well, we wish you a lot of luck, I guess. That's very nice. Ken's a good guy. I've heard him too. And who are the other?
He's really down to earth and so practical and so common sense.
We like that.
Yeah.
That's good. But I think Jeremy Hansen.
He's a progressive from Berlin who's running as a Democrat. You have Gordon Bach, who ran 2 years ago. And then two new names, Denise McMartin and John Stevens.
Oh, very nice. Excellent. Well, the choices we have to make.
It's good for people to have choices, and it's good to see people interested in wanting to serve.
Exactly. Because it's a lot of commitment. It's a big commitment. So, Ann, thank you very much for being on the show. Thank you, Ben. Thank you all for tuning in. We'll see you next week. And in the meantime, keep listening beyond the sound bites.